At this very moment, somewhere in my body and in yours is a cell that has transformed to become cancerous. There are around 35 trillion cells in my body, each with 6 billion base pairs worth of DNA. It is inevitable that somewhere in those 200 sextillion base pairs in my body and yours, a mutation has occurred that has released a check on the growth potential of one of those trillions of cells. And yet, cancer, the clinical syndrome associated with unchecked growth of a cell type, is not inevitable. More than a century ago, Paul Ehrlich hypothesized that something must be keeping those nascent cancers arising continuously throughout our lives in check. That something, he believed, was the immune system. And though there have been fits and starts in the research over time, Ehrlich's hypothesis has proven to be a powerful one. Cancer, the clinical syndrome, can be thought of as a failure of the immune system. This is why the most significant breakthrough in cancer treatment in recent memory, immunotherapy, has been so successful and shows so much promise. It gives the immune system a second chance to get right what it missed in the first place. Researchers have been looking for ways to make these new drugs even more powerful. One area of particular promise is anti-tumor mRNA vaccines. These would be custom-coded mRNA molecules tailored to bind to a specific marker on your specific tumor to call in the immune system troops. But as one group was exploring the potential of these targeted mRNA vaccines, they found something incredibly surprising. Untargeted mRNA vaccines seem to work too, like mRNA vaccines that have nothing to do with cancers at all. And it just so happens we have a lot of mRNA vaccines around. I'm about to tell you about a new medical study that may reshape the way we treat cancer in the coming years and decades. It's a study that suggests that the mRNA COVID vaccines, those of Pfizer and Moderna fame, may improve overall survival in people with cancer receiving immunotherapy, and not by a small amount. The paper, appearing in the journal Nature, is a real tour de force, including experiments ranging from cell culture to mice, to healthy humans, to humans with cancer. But I'll start with the most dramatic finding first, how COVID vaccines may help treat cancer. The researchers explored this across a few cohorts. The largest was a group of 884 individuals with non-small cell lung cancer who started immunotherapy. 180 of them received a COVID mRNA vaccine within 100 days of initiation of that therapy. Those who received the COVID vaccine had a near doubling of overall survival, from a median survival of 20.6 months to 37.3 months. That is, after adjustment for 38 patient-specific variables ranging from demographics to characteristics of the underlying tumor. Similar results were found when they were looking at people with unresectable stage 3 lung cancers or even metastatic stage 4 lung cancers. They then examined a cohort of patients with metastatic melanoma. Out of 210 patients starting on immunotherapy, 43 received a COVID vaccine within the first 100 days. The median survival in the unvaccinated group, 27 months. Median survival in the vaccinated group, at least 40 months. The majority were still alive at that time point. They also scoured their electronic health record for all biopsy-proven cancers where immunotherapy was used, netting 5,317 total cases. The rate of death from any cause was 27% lower among those who had received a COVID vaccine within 100 days of initial therapy. Now, it didn't matter which mRNA vaccine the patients got, although if you squint at this graph, you might think that Moderna, which carries a slightly higher mRNA dose, has the edge. And it really was mRNA vaccines. Receipt of the flu or pneumonia vaccine had no effect on survival among people receiving immunotherapy for cancer. Okay, let's take a breath here. These are some pretty startling results with powerful implications, but let's think through where analyses like this could go wrong. First off, I'm sure you're asking the same question I was as I read the article. Are these people just living longer because they weren't dying of COVID? It doesn't look that way. We have to dig down to extended figure 2A to answer that question. It's a very detailed article. But what you see here is that the protective effect of the COVID vaccine in terms of overall survival was not evident in patients with cancer who were not receiving immunotherapy. If we were just measuring the fact that COVID vaccines save lives, we should see that effect across all patients. Next issue, and shout out here to the folks at Citra, my research group, because we love talking about this, immortal time bias. This is a sneaky statistical artifact that arises when you define an exposure, in this case COVID vaccination, based on something that can occur after the clock starts ticking in terms of survival, in this case the first dose of immunotherapy. Patients in this study had 100 days after that immunotherapy dose to get a COVID vaccine, but they could be called a vaccinated patient from time 0. That gives an edge to the COVID vaccine people, even if the vaccine has no effect. But the authors were prepared for this and present a time bias corrected version of their results here, limiting outcomes only to people who survived for the first 100 days after therapy. Same deal, about a 40% reduction in mortality rate. We also need to remember that this was not a randomized trial. The people who chose to get the COVID vaccine would have been different in systematic ways from the people who didn't. And while the authors try to account for this both through their 38 variable statistical adjustment and through a propensity matched sensitivity analysis, we can't be 100% sure that COVID vaccination isn't just a convenient marker for a variety of healthful behaviors that perhaps they couldn't capture in the data. That said, if this was all good old-fashioned confounding, the animal studies in the paper wouldn't have looked so dramatic either. Let me walk you through some of those findings. The researchers took mice strains, which are prone to developing melanoma or lung cancer, and exposed them to various combinations of immune therapy, COVID vaccines, or both, and measured the size of tumor over time. In an untreated mouse, you can see here how tumor size grows from something like 200 cubic millimeters to 1600 cubic millimeters from day 13 to day 19. When immunotherapy is given alone, the size is reduced. Interestingly, when just the mRNA vaccine is given alone, the size is also reduced. But when the immunotherapy is given with the mRNA vaccine, the result is dramatic. There is clear evidence of a synergistic effect here. Interestingly, there does not appear to be anything special about the COVID mRNA vaccine specifically. It's the mRNA that matters. The researchers replaced the mRNA inside the COVID vaccine from one that produces the COVID spike protein to one that produces an antigen from cytomegalovirus. The tumor suppressing effect was the same. They conclude that it's not what the vaccine is targeted against that matters, it is the fact that the vaccine contains mRNA. The likely mechanism here is stimulation of the innate immune system, cells and cytokines designed to react rapidly to a foreign invader before the more sophisticated, targeted immune system ramps up. This opens the door to tweaking the vaccines a bit to increase their innate immunogenicity. For example, the researchers replaced a modified uridine in the conventional vaccine, there to limit immunoreactivity, with unmodified uridine. I'm sure the post-vaccine symptoms weren't too pleasant for the mice who got that version of the vaccine, but the tumor-suppressing effect was even higher. Now, trying to absorb all the data presented in this paper is a challenge in and of itself, but the picture it presents is fairly clear. Cancer is a failure of the immune system. Immunotherapy drugs like checkpoint inhibitors help to ramp up the immune system to fight off the cancer after it's taken root, but further therapies to goose the immune system hold tremendous promise. And yet, in the future, custom mRNA vaccines targeted specifically to a given tumor may be the standard of care. For now, though, those therapies are costly, slow, and experimental. The fact that something as cheap and widely available as the COVID vaccine holds the potential to cut cancer mortality in half feels almost too good to be true. But I'm reminded that in medicine, technology often gives old ideas new life. In 1891, a physician named William Coley noted that several patients with cancer had seemingly miraculously recovered after surviving an unrelated bacterial infection. He hypothesized, I think correctly, that the infection had awakened their immune system, which then attacked the malignant cells. He would spend most of his life exploring whether infections or products of bacteria could help to fight cancer, and while he never perfected the approach, he is still referred to as the father of cancer immunotherapy. For what it's worth, Coley focused on strep pyogenes, and here we are more than a century later focusing on a virus that killed millions around the globe, but in a strange twist of fate, may lead to more lives than that being saved. For Medscape, I'm Perry Wilson.